So my remarks are going to be structured as stories, science, and scale. I'll start with the story. Purnamaya is a woman who spent 25 years of her life living in a tent in a Nepalese refugee camp. 2 years ago, she was resettled to Nashville, Tennessee. She found herself in a foreign land, overwhelmed by dark memories, and so she spent her days lying on a pile of blankets in the corner of her house, too depressed to even climb into her own bed. Eventually, her husband took her to a refugee clinic in downtown Nashville, and that's where they met Hannah, an impact community health worker. Hannah spoke gently to Maya in her native Nepalese tongue, and she asked Maya what she thought was going on and what she thought would help. And Maya slowly explained that she was dying of loneliness. So Hannah visited Maya each week in her home and eventually coaxed her to come out and meet a group of other Bhutanese women. And together they reminisced about their homeland, brought in fresh fruits and vegetables from their garden to share. Week by week, Maya began to feel joy again. And that joy carried her to work with Hannah on other things, more tangible things, seeing a behavioral health specialist, getting transportation to those appointments, finding low-cost medications for her depression and hypertension. She began to spend her days outside gardening and her nights sleeping well in her own bed. For me, this story is what it means to think about the whole person. Yes, Hannah needed linkages to behavioral health and referrals for transportation, but she needed something more. And that more is love and the power of human connection. But how do you turn the power of human connection into a scalable intervention? That's the question that has motivated my team and I for the past decade as we've built the impact model. Impact is a standardized, scalable community health worker program. So it's a model by which trusted lay people from within local communities provide person-centered and tailored support. Yes, these community health workers can help individuals find resources like housing or transportation, but first they take a step back. And as Hannah did, they get to know each patient as a person and ask her what she thinks she'll need to improve her health. And then they do those things. What Hannah did for Maya was magical, but not accidental. Hannah was selected using a specialized algorithm designed to identify natural helpers and listeners. The questions that she asked Maya came from an interview guide that we designed after interviewing thousands of low-income patients. She documented her notes in an app that we co-designed with community health workers, and she received supervision from a manager in her Nashville clinic whom we trained using our online interactive platform. We've studied this approach in 3 separate randomized control trials, which have demonstrated improved chronic disease control, primary care access, mental health, and quality, while also achieving a 65% reduction in total hospital days. So these outcomes from RCTs translate to an ROI of $2 for every dollar within the fiscal year. And that's allowed us to fuel growth, serving about 10,000 patients in the Philadelphia region. And now we're building impact programs across the country so that a Nepalese woman in Nashville, Tennessee, a veteran in Pittsburgh, a migrant worker in Louisiana can essentially use the same standardized operating system that will unlock their ability to unleash the power of human connection. I'm really looking forward to the discussion, and I wanted to leave us with a brief point. As I look around the room, there are a lot of experts here, but we aren't the people that we are trying to serve. So I do think it's important that we anchor this conversation in what actual low-income people would want in order to improve their own health. And we have that data. We have talked to 10,000 low-income individuals and asked them what they think will improve health. Here are the answers. Most individuals want informal psychosocial support like Hannah's gardening group, or support for making health behavior changes like joining a weight loss contest or getting quit smoking patches. About 15% want referrals to resources for daily life like housing or transportation. 11% want support with health system navigation, and 2% want help with a medical issue like foot pain or shortness of breath. So as we further our discussions today, I think it'll be important to keep in mind how this patient perspective aligns or doesn't align with our design and investments. Thanks.